Hi, everyone. I'm Yen Bui, Chair of ISDM Professional Education Committee, and welcome to all of you to our special World Rabies Day webinar on this fascinating disease. Our moderator today is Dr. Albie Dufresne, CEO of Travel Doctor Corporate in Johannesburg, South Africa, and Senior Honorary Lecturer, Faculty of Health Sciences, Wits University, Johannesburg, South Africa. He is also a co-anchor of ISDM podcast series, Travel Unraveled. And over to you, Albie.
Thank you very much, Yen, and welcome everyone. You've just heard where I am. I'm in the real South Africa in Johannesburg, and it's my pleasure to be your moderator today. So just a few announcements before we get started. Yen made sure that I stay in line, so I've got a very perfectly scripted script to stick to. So first of all, we just want to point out to everybody that this program is being recorded and all attendee audio and video is muted, so you can't throw or shout at me. Today's presentation will last up to 90 minutes and includes question and answer opportunities. So please submit your questions at any time throughout the presentation to the Q&A panel at the bottom of the screen. Please note that the chat is not monitored for questions. To ensure your question is received, please use the Q&A panel, not the chat panel. And during the Q&A at the end of the webinar, our presenters will answer as many questions as time allows. You may turn on closed caption services during the webinar. There is a live caption button on the bottom of the Zoom screen. And please note that this is a free service provided by Zoom, and it may not be 100% accurate. The slides for this program can be accessed on the Handouts tab of this program, located at learning.isdm.org. You will find the webinar page on your Learning at ISDM dashboard once you are logged in. Now that we've gone over the announcements, ISDM is pleased to present this online educational webinar, Rabies in Travelers, Deadly but Preventable. Unfortunately, the program is presented in American, so apologies to our British viewers. The webinar is produced by the Professional Education Committee of the ISDM, and we want to say a special thanks to our sponsors, Bavarian Nordic and Sanofi, that helped provide the program. The program has been planned by the planning chairs, Dr. Yen Bui, who is looking very smart. I love her pearls. She is the chair of the Professional Education Committee of the ISDM. Thank you very much, Yen. And Dr. Darwin Scott Smith, who is the co-chair, and Dr. Lin Chen, who is past president of the ISDM. So with that, it's my pleasure to welcome notre premier intervenant, Dr. Ula Itani, MD at l'Institut Pasteur, Centre Médical Paris, France. Over to you, Ula.
Thank you. Thank you, Albie, for that presentation. Thank you for inviting me to speak at this webinar. So I'm going to share my slides. So as Albie said, I work in the Institut Pasteur in Paris. We have a very large travel clinic where we see around 50,000 travelers per year. And we also have a rabies center where we see around over 1,000 travelers per year for post-exposure prophylaxis. So I thought this webinar would be a good occasion just to talk about Louis Pasteur, because we really like him a lot over here in the Institut Pasteur. And just to remind you that he's the one who developed the vaccine against rabies in 1885. And so here you have a photo of him vaccinating a child who was exposed to rabies. So I have no conflicts of interest in relation to this presentation. First of all, I'll speak to you about the French guidelines in France, which don't differ much from what will be presented after and what is recommended by the WHO. Then I'll show you our center's experience and some practical cases. So the idea being to discuss prevention and post-exposure prophylaxis from a non-endemic country's perspective. So first of all, for our French guidelines, in France, we have 2 vaccines available. Both are produced in cell cultures. We have the Rabies Pasteur, which is produced in Vero cells, and we have the Rabies pur, which is produced in purified chick embryo cells. So here's a photo of our French fridge. So the WHO approved in 2018 a 2-dose regimen for pre-exposure prophylaxis, but up to very recently in France, the product characteristics of both vaccines did not include this regimen. So our official guidelines also did not include this regimen. They only recommended officially the 3-dose regimen. Things have lately changed. At the end of last year, Rabies pur included in its product characteristics the 2-dose regimen. So now, since a few months, our official guidelines also recommend it. And recently, Rabies Pasteur has also changed its product characteristics. So our guidelines will be changing next year to include both vaccines. But up to very recently, only the 3-dose IM regimen was approved in our official guidelines. Although that was the case, the vaccination centers did not in real life wait for our recommendations to change. My colleagues carried out a survey 2 years ago in France among over 70 centers. And what you can see is that already at that time, 3/4 of our vaccination centers had already adopted the 2-dose regimen for pre-exposure prophylaxis. 1/3 systematically, and the others for cost or practical reasons. And in our center, we do use the 2-dose regimen with both vaccines. One of the problems that did emerge with this 2-dose regimen is that we started to see travelers come back from their travel who reported to us that during their travel, they had had issues with the 2-dose regimen, and that during the travel, people would say to them, this is not a valid prophylaxis regimen. So 10% of the centers surveyed said that they also had seen travelers who had issues during their travel. So now we try to include, what we did is that we included in our vaccination cards, I tried to put you a photo here, a little note that specifies that the 2-dose regimen is a valid pre-exposure prophylaxis. We also have the little stamp. And we always try and insist and educate our travelers and remind them what it actually means to be vaccinated against rabies in pre-exposure prophylaxis. And our nurses, when they see them for their 2nd dose at 7 days, they always try and ask the patients and make sure they understand what it means to be vaccinated. So that's for pre-exposure prophylaxis. So pre-exposure prophylaxis in France can be done anywhere. It can be done in your pharmacy. It can be done with your doctor. It can be done in any vaccination or travel clinic. For post-exposure prophylaxis, it has to be done in a specific center, a rabies center, because it's not a frequent problem in France. We're in a non-endemic country, and so it requires expertise. And so I put you a map over here of the centers in France. There's basically 1 center per sub-region in the country. And so sometimes patients have to travel 1 or 2 hours or have to drive 1 or 2 hours to come and see us and get vaccinated. Over here, I reminded you the type of exposures because post-exposure prophylaxis depends on the type of exposure. I think Agam will talk to you about it later. But if you just touch an animal, it's considered as a type 1, a category 1 exposure. If you're nibbled or bit very softly or scratched, we have a type 2 exposure. And in case of a more profound wound or a profound scratch, or if you're licked on a wound which is on broken skin, we say it's a category 3 exposure. So for post-exposure prophylaxis, the last French guidelines were published just after the WHO's position paper in April 2018, and we basically follow the same guidelines in France, which is no prophylaxis in case of a category 1 exposure, vaccination in case of category 2 or 3 exposure, and additional immunoglobulins, rabies immunoglobulins, in case of category 3 exposure. Antibiotics, analgesics, if needed, of course. In our center, we do not recommend the use of anti-herpes B treatment in case of exposure to monkeys. So the three regimens, I think we'll speak to you about them later, are accepted in our in France in our guidelines. In our center, for practical reasons, we don't use the intradermal route, so we only use an SN or a Zagreb regimen. If we have to initiate a regimen, we usually use a Zagreb regimen because it's much easier. Patient has to come back less. And if an SN regimen was initiated abroad, in that case, we will always try and use the modified version and use 4 doses instead of the 5 doses. We do not recommend post-exposure prophylaxis if it was already correctly undertaken in the last 3 months. And most importantly, if any doses are delayed, which is actually very frequent, we'll see a few cases later, but this happens frequently, we always try and resume vaccination. We try not to restart everything. So we have the same 2 vaccines for post-exposure prophylaxis. As I said, both routes are accepted, IM or ID. We do not use the ID route for practical reasons. We always try and check what route the traveler received abroad, because it happens quite frequently that the traveler is going to tell us they received an intramuscular vaccine in the gluteal area, which is not recommended. Sometimes we also see vaccination cards where it's noted an intradermal injection, so 0.1 milliliters, but intramuscularly. So that's also not recommended. So we also always try and make sure the route they received is correct. For rabies immunoglobulins, we only have human immunoglobulins in France. We do not perform skin sensitivity tests before, but we do ask our patients to remain 30 to 45 minutes in our center just to make sure they don't present with any immediate allergic reactions. And maybe the only thing that I should mention that does differ with the WHO's guidelines is that it is recommended in our guidelines to inject the remaining immunoglobulins intramuscularly. Although the benefit of doing so is thought to be very limited. So that's for our official guidelines. Now I'm going to show you a little bit what we see in our center. So we took back the data from 5 years. This does include the COVID era, so obviously we saw a little less travelers at that time. But nevertheless, we did see nearly 3,000 travelers in 5 years who are exposed to rabies abroad. Just as many men as women, mostly young adults, 29 years of median age. And when we look at the distribution of ages, what we can also see is that more than 15% of the patients are children under 15 years. So that's something important too for our pre-travel advice, to really insist on parents that children are a risk population to be they are frequently exposed to rabies, and they have to make sure that they don't touch animals, pet animals, feed animals, etc. The median time from exposure to consultation to our center was 11 days. So this actually just reflects the fact that most of the patients start prophylaxis abroad. And we mostly see travelers who come back from 2 regions, Southeast Asia and North Africa. And when we look at the details of countries, 5 countries account for over 50% or nearly 50% of our exposures, sorry. So in Southeast Asia, Thailand and Indonesia, which are very popular touristic destinations for French tourists. And then we have Morocco, Algeria, and Tunisia in North Africa, which are historically linked to our country, and many travelers go back there to see their families. Concerning the type of exposures, 1/3 of exposures are category 3 exposures. Over 80% of the travelers start their prophylaxis abroad. So most of the time we have to continue an already initiated management. So that means juggling with delays or sometimes unknown vaccines or other unknown factors. And that also means that over 15% of our travelers do not start prophylaxis immediately. So is it because they lack of awareness? Is it because they don't perceive the risk? Is it because they prefer to disrupt their travel and come back and get treated in France. We don't have much data on that for the moment, but we're trying to look into it. For the animals involved, half of the time nearly it's dogs, and then we have monkeys and cats. Cats, over 50% of exposures to cats happen in North Africa in our experience, and it's significantly more frequent among children. And monkeys is mainly in Southeast Asia, and particularly in two touristic destinations, Monkey Forest and Monkey Beach. So I would tend to encourage you, we always try and raise awareness among our travelers traveling to Asia to really try and avoid contact with monkeys, not get close to them, not feed them, because most of the time that's how they're exposed. So now I wanted to show you a few practical cases, because when I started working at the Rabies Center, I thought that this is going to be very easy. There are very clear guidelines. All you have to do is follow them and everything will be very simple. And then as usual in medicine, the patients were never what they were supposed to be. They never looked like in the books, and we always have to adapt. So I thought I would show you some practical cases. This is actually a mosaic, which decorates the crypt of Pasteur's tomb, which is in our institute. And once a year, people gather on the anniversary of his death, which is on the 28th of September, which is also the same day as Rabies, World Rabies Day. So as I mentioned earlier, we often see healthy travelers who come back and for who a 5-dose SN was started during travel. So I put you here a few examples of papers that our travelers come back with. Sometimes we even see a 6-dose, which is recommended at 3 months, and sometimes even more doses. So we always try and propose a 4-dose regimen because it's easier and cheaper, and also because it's recommended. Sometimes, however, it can be complicated when a traveler receives 2 contradictory medical advices. Sometimes we feel that the patient is hesitant or not convinced. It makes him anxious. He doesn't understand, or she doesn't understand why they got 2 different medical advices. So in those cases, we just tend to do the 5th dose. But if possible, we try and change the schedule and always do a 4-dose schedule. So that's the easy type of change of schedule. Sometimes it's a bit more tricky. So I tried to put you a few examples of patients we've seen recently here. This is a 71-year-old patient who was bit in Algeria by a cat and started an SN regimen during travel. So got a 1st dose on the first day, her 2nd dose on day 3, and instead of coming on day 7 for the 3rd dose, came on day 11. So as I said earlier, we always try and follow the WHO's position paper, which is if any doses are delayed, we're not going to restart everything. We're going to resume vaccination. So that's what we did here. On day 11, we did the 3rd dose, even though she was 4 days late. We did a 4th dose 7 days later. But then because we're not completely in the box, we're not following the guidelines, and also to avoid any legal problems afterwards, if we're not completely following guidelines, we're always going to perform a serology after to make sure it's okay. So we arbitrarily decided that if the dose is delayed up to 48 hours, we consider it's okay, but beyond, we always resume doses. We're not going to restart everything, but we'll always do a serology to ensure that although the schedule was not performed as recommended, the patient is nevertheless protected. We have a serology to prove it. So here we have a similar case. This time the patient started with a Zagreb regimen and did his first 2 doses on the first day, did not come back at day 7, and only came back at day 21 for the 4th dose. So we did our 3rd dose on day 21, a 4th dose 7 days later, and again a serology to make sure the protection was sufficient, which it was. And this again, same case, SN regimen started abroad. This time, instead of coming on day 3, the patient came on day 5. So here we continued, we didn't restart everything, but because the delay was only of 48 hours, we didn't judge necessary to perform a serology afterwards in this case. Some other cases of change of schedule. This patient started an SN regimen in Cambodia and followed the schedule correctly, but reported that the first dose was administered in the gluteal area. And that's something, as I said previously, is not recommended. So we could have done simply the 4th dose and check with the serology that everything's fine because of the route of administration. But sometimes what we also do is we're going to do a full SN. So we do a 5th dose. Like that, we're sure at least that the patient got 4 doses correctly, and it helps us avoid serology. This is another example. So we always try, if possible, to resume and not restart, but sometimes it does seem easier to restart. This patient was bit by a monkey in India, started an SN regimen, and then never did the 2nd dose on day 3, and came back on day 6 for the 2nd dose, so 3 days later. And the vaccine used was unknown. So if we resume vaccination in this case, we're faced with delay of schedules, unknown vaccine, a necessary serology at the end. So, and in either way, the patient is going to have to come back twice to get 2 additional doses. So in this case, for us, it feels easier to restart the regimen because at least we're sure it's as scheduled with correct vaccines. And this is something we are conscious that we can do this because we're lucky enough to be in a country where we have easy access to vaccination. And this last patient was just to show you that, so in this case, the patient had only received 1 dose of an unknown vaccine and had delay, so it was easier to restart. In this case, the patient had 3 doses of an unknown vaccine, and so had already received 3 out of 4 doses, and there was no delay. So obviously, in this case, we're not going to restart everything. Although we don't know the vaccines, we performed the last dose, and then 2 weeks later, we did a serology to make sure the patient was protected. So as you may have noticed by now, serology is kind of our joker card. Whenever there's something wrong, it's not the right schedule, an unknown vaccine, not the right route of administration, we continue vaccination, and then we're going to perform a safety serology. And it helps us sometimes juggle complicated cases. This patient, for example, had started an SN regimen abroad, but never continued it because the animal was still alive. And then 3 years later, was again exposed and restarted a regimen. They told her that she had to do a full regimen because the first post-exposure prophylaxis was not complete. But when we looked at this, we said to ourselves, this kind of looks like a pre-exposure prophylaxis. So when we saw her, she had already received 2 doses 3 days apart. So we chose not to do anything and to simply perform a serology 15 days later, which showed that the patient was correctly protected. And this last case was just to show you a case where it's quite often we see patients who receive immunoglobulins in the area very close to where their vaccine was administered. So we always try and check serology in that case. And in this case, the patient was not protected, so we had to do an additional dose. And the additional dose allowed the patient to be correctly protected. So the use of serology is part of our guidelines. Our guidelines say that in case patients are immunocompromised, if there's a delay in schedule, if we don't know the type of vaccine, the type of route used, we have to do serology to make sure everything is correct. And in our center, we also additionally, we have a wider use of serology. We also ask for serologies for elderly patients, for pregnant women, for patients with high body mass indexes, in case there's an infection during in between the doses, and up to recently for the 2-dose regimen because it was not officially in our guidelines. And an adequate response is considered a serology over 0.5 international units. This was just to show you a paper. I'll pass on this quickly, but this is a paper we published last year in response to a case report of failure of post-exposure prophylaxis in an elderly patient. And we reported our experience. And just to show the fact that in our center, I think it was on the last 7 years, we did see 5 patients who did not respond correctly to the 4-dose regimen. And some of these patients were elderly patients with no major health issue. And we suggested that either a serology should be performed or a 5th dose, but that we should be careful in this population. And now just to finish, I added two last slides. The first one on nerve tissue vaccines, which are no longer recommended because of the severe adverse reactions that they can induce, and also because they are less immunogenic than the modern vaccines. We still do see patients who come back mainly from Algeria, but also sometimes from Bolivia, where they seem to still be using nerve tissue vaccines. So for these patients, we restart completely the regimen, and we use cell culture vaccines. But what I wanted to add with this is for travelers traveling to Bolivia or Algeria, we may tend to recommend pre-exposure prophylaxis more easily because we know that post-exposure prophylaxis can be complicated during travel. So I think it's something that we should keep in mind for our pre-travel consultations. We often consider how long the patient is traveling or in what conditions, but we should also add to the algorithm of decision-making the fact that post-exposure prophylaxis can be limited in some countries or areas. For example, lack of modern vaccines for Bolivia or Algeria. This can also apply to rabies immunoglobulins. In some areas in the world, in sub-Saharan Africa, access can be very limited. And so these factors should be taken into account in our pre-travel consultations. And finally, I just wanted to say a last word on late consultations, because we always, from time to time, have that typical phone call where a patient's going to phone us and say, yeah, I was bit by a stray dog in India, but that happened 7 months ago, so I think I'm okay and I don't need to come and see you. So this is what happened a few weeks ago. I saw this patient who phoned for the same reason. So we follow WHO's guidelines, which say that the likelihood of developing rabies declines progressively during 12 months and only occurs very rarely after 12 months. So in our center, if a patient is exposed before 12 months, we're going to start prophylaxis. And if it was after 12 months, we don't. And I did present to you earlier the medium time from exposure to consultation, which was 11 days. But what I wanted to add to that is that we do see 5% of our patients who consult over a month after exposure, and 1% consult over 6 months after exposure. And in the last 20 years, 5 travelers have died in France from rabies. So this may not seem like a lot when you look at the burden of rabies in the world, but it does remind us that rabies is of rare occurrence in travelers, but when it does happen, it's a fatal disease and it's something we can prevent. So deadly, but preventable. And so part of the prevention passes through our pre-travel clinics, especially in non-endemic countries, because when you ask these patients, why did you take 6 months to come and see us? They're always going to answer, well, I wasn't aware of the risk. Many of them, I've already heard several times patients say, well, I thought rabies doesn't exist anymore in the world because we're in a non-endemic country. So raising awareness is essential. It's always better to tell them not to get exposed. It's better to tell them not to touch animals. It's good to get vaccinated. But I think the most important thing, if there's one thing they should remember, is to know that rabies still exists and that they need to seek medical advice in case of exposure. So there we go. I finished. I hope you learned a few things. If there's a few take-home messages, I would suggest in pre-consultation is essential, as I just said, in preventing rabies in travelers. Simply telling them it exists and advising them to always seek medical care. It can help save a few lives. If vaccination is considered, taking into account the access to correct post-exposure prophylaxis is also essential. And for post-exposure prophylaxis, it's not always possible to perfectly follow the guidelines. So it's important to be pragmatic and try and find the simplest cheapest solution, but without compromising their safety. There we go. I'm done, Albie.
Thank you very much, Ula. Merci beaucoup. And that was a great presentation with some very nice, clear, concise guidelines, gratefully not in French, but very clear. So I'm going to give Dr. Agam Rao an opportunity to put her slides on, to share a screen with us. While I introduce her, Dr. Agam Rao is a captain with the U.S. Public Health Service, Department of Pox Virus and Rabies, on that branch. No pun intended about that. We're not talking about Mpox, we're talking about pox. And she's with the DHCPP and the NCEZID, Centers for Disease Control, in Atlanta, Georgia, America, the United States of America. Thank you very much, Dr. Rao. Over to you.
Thank you very much.
Please unmute. There you are.
Thank you. So I'm going to speak mostly about pre-exposure prophylaxis for rabies, but I'm also going to speak to post-exposure. And towards the end of my presentation, I will compare our US ACIP recommendations with WHO recommendations. I think Ula has done a great job in presenting a lot of that information. So this will be an opportunity to reinforce those same things. So first off, we in the US tell people that there are many strategies to prevent human rabies. There's avoidance of risky behaviors. I mean, people will pet animals when they travel and they shouldn't be doing those things. So we'll first stress those things. Vaccination of pets and wildlife is very important. There's proper use of personal protective equipment for laboratorians that is also critical. And then after that, of course, pre-exposure prophylaxis or PrEP and post-exposure prophylaxis or PEP. So it's the pre-exposure prophylaxis or PrEP that we updated here in the United States in May of 2022, and those have been published. And I would recommend reviewing the citation here that's at the bottom of the screen. That is the published recommendations, and particularly there's a table in those that I'll show later on in this presentation. But that table really captures all of the information that I'll present in this pre-exposure section. So PrEP is not indicated for the general US population because obviously we don't have as much rabies here in the US. And so this figure here shows that regardless of people's age, there's a large proportion of the US population that's never going to have a rabies virus exposure and is therefore not recommended to receive the vaccine. Now, for those who do have an exposure in the United States, they obviously, most of those individuals, as I mentioned, do not get pre-exposure prophylaxis, so they would get post-exposure prophylaxis. In the US at this time, it is post-exposure is still rabies immune globulin and 4 doses of rabies vaccine. So that is different from what is recommended by WHO. And I'll talk a little bit about that later, but just want to point out this slide's, the intention is just to show that most people do not get PrEP, and it's just post-exposure prophylaxis that those individuals would get if they have a concerning exposure. Now, the US population, the people who are recommended to get PrEP are those people who are at elevated risk. And by that, we mean that they have unrecognized exposures to rabies virus. They have unusual or high-risk exposures, like in a laboratory setting. And then they might have recognized exposures, like a veterinarian who knows that they got bit by an animal while they were caring for them. The risk categories and the corresponding recommendations that are redefined in our updated ACIP recommendations. So that's the link that I showed on the previous slide, and that's that table that I previously showed. Now, recognized exposures include certain travelers to canine rabies endemic regions, and we do describe that in more detail in CDC's Yellow Book, which is our travel guidance. So the ACIP PrEP updates have redefined the risk categories. There's a new minimum rabies antibody titer. It's now 0.5 IUs per ml, so it's now in alignment with what WHO does and what Dr. Itani just presented. There's fewer vaccine doses up front as part of the primary vaccination schedule, so it's a 2-dose series instead of the previous 3-dose series. And there are flexible options for ensuring long-term immunogenicity. I'll talk a little bit more about that in a bit. There's also less frequent or no antibody titer checks for some risk categories. So as Ula mentioned, we too rely a lot on serology, but there's fewer of those recommended. There's less of that recommended. And then of course there's clinical guidance as well for specific situations. I'll go into the first of these bullets first and then end on the clinical guidance before we move into post-exposure prophylaxis. So this is a screenshot that is actually better captured from presentations that were given to the ACIP, but that table 1 that I mentioned in the ACIP recommendations is a little more thorough and is what I would recommend referencing if you're looking to see what our detailed recommendations show. So the first column shows the risk categories, and we define the risk categories as 1 through 5, depending upon the type of risk that you have, where 1 is the greatest risk, and that's typically people who have been, who are working in laboratories and have live rabies virus exposure in research and diagnostic laboratories, including high concentration virus and unusual exposures like aerosolized virus. And 5 is lowest risk exposure. It's the typical person in the US who does not get pre-exposure prophylaxis, as shown here. Now, I'll go into each of these risk categories in more detail. So risk category 1, that's where high concentrations of rabies virus, recognized and unrecognized exposures, and can be unusual exposures like aerosol generating procedures. These are typically laboratorians. The recommendation is for a 2-dose rabies pre-exposure prophylaxis schedule, and then serologic titers to be drawn every 6 months. Now, if that if the titer is less than 0.5 IUs per ml, which is the WHO minimum antibody titer, then a booster dose is recommended. Risk category 2 is individuals who have recognized or unrecognized exposures, but it's unusual to have the unusual exposures like the aerosol generating procedures for example are unlikely. And these individuals are typically those who frequently handle bats or have contact with bats or enter high density bat regions. They're also people who perform animal necropsy. So people who collect suspected rabies samples and perform necropsies would fall within this risk group. And for them, it's the 2-dose pre-exposure schedule, but the serologic titers are drawn, and they're drawn every 2 years. Again, the booster is given if the titer is less than 0.5 IUs per ml. Moving on to risk category 3, this is where you get into travelers. So the exposure to only recognized exposure, so a traveler they would have an actual bite or a scratch from an animal, and that's what we mean by recognized, that an actual bite or a scratch occurred, and that the risk is for longer than 3 years for risk category number 3. So you can see here veterinarians are included typically, the typical veterinarian, unless they're performing necropsies, and then travelers as well. Risk category 4 is for the same people, but their risk is for longer than 3 years. I'm sorry, is for less than 3 years. So the distinction here is that, so if someone is has one trip that they're planning to a rabies endemic region, and they're not planning on ever traveling to these countries again, or they're later in life and they're not planning on doing so again, then they would fall within risk category number 3, and they wouldn't have to worry about long-term protection. But risk category 4, because they're not worried about long-term protection. But risk category 3 is the traveler who anticipates future travel, or is a veterinarian who anticipates future risk, and then those individuals we would be interested in ensuring that there's long-term protection. And again, travelers, as you'll see, are in these 2 risk categories. So the 2-dose PrEP series is what is recommended for risk category 3. And then in order to ensure that there's long-term protection, we have additional steps in the US. And I know this differs from what's recommended in other countries, but if you do anticipate a need beyond 3 years, we recommend either a one-time titer check, and I'll go into more detail in a bit, or a one-time booster dose. And the reason for this is that we didn't, the US ACIP reviewed the data and didn't feel quite as confident that the 2-dose series alone would provide protection beyond 3 years. I mean, perhaps it does. We just need more data for the ACIP to review before ACIP felt comfortable making that decision that a 2-dose series alone was enough. But for those individuals in risk category 4 who do not anticipate having any risks, having any exposures beyond 3 years, it's just the 2-dose series, and there's no titer or booster dose needed. So I hope that distinction is clear. It's if people have that risk beyond 3 years, that the ACIP recommendations do call for additional steps to ensure that they have protection beyond 3 years. So risk category 3, as an example, just so that you can see what I mean about that, that additional step that's needed. So the 2-dose series is given before they travel, then they travel here as shown in this airplane here. And then up until year 3, we believe they have protection, but if they anticipate needing protection beyond 3 years, what ACIP recommends is either a one-time booster dose at any point before year 3, or a one-time titer check between years 1 and 2, as soon as year 1. And if that titer is less than 0.5 IUs per ml, then no further action is, sorry, if it's greater, no further action is needed. And if it's less, then a booster dose is indicated. So the reason we give these 2 options is depending on people's insurance, depending on people's jobs, depending on people's preferences in general. They may prefer to just, to go straight to the booster dose, and others might prefer to get the titer check first. So if these individuals who are previously vaccinated, that is, they got the 2-dose PrEP series, if any exposures occur, their rabies PrEP series is only a 2-dose series of 0 and 3. So that's what we consider previously vaccinated. Anyone who got the 2-dose series and has an exposure up until 3 years or beyond 3 years, they receive this either this titer check or this booster dose, and they have that exposure. Regardless of which of these happens, they're considered previously vaccinated and they get the 2-dose post-exposure series. Now, for people who are previously vaccinated and the exposure occurs, I think I explained that actually. It's just there's 2 different options here. One is where the exposure occurs before 3 years, and one for after 3 years. Now, moving into clinical guidance. So we get these questions a lot. People are very confused by our recommendations and why they differ from WHO's, and what to do if someone didn't get a booster, didn't get a titer, what to do. So these are also figures that are from the ACIP recommendations that I mentioned were published in 2022. So first off, in the first panel up above, if you have a patient, how do you manage a patient who was non-adherent to the recommended one-time titer or booster dose, but who is, but you want to realign to the ACIP recommendation? So you could see here, they got the 2-dose series at days 0 and 7. And then on year 3, they were supposed to get a titer or booster. They did not do that. And then a titer was checked after that. And depending upon what that titer showed, if the titer was low, then they, so rabies exposure, if titer checked in realignment, they can realign with the ACIP recommendations as long as they've not had an exposure. And then going forward, if they have an exposure, then they would be considered previously vaccinated, and they would just get PEP for the two doses of the rabies vaccine. And our recommendation also is intramuscular, similar to what Ula describes. We don't have intradermal in the US. Now, for our next situation of management of a patient who is non-adherent to the recommendations for the one-time titer or booster dose, but they have an exposure, so they cannot realign, but they actually have an exposure after year 3. For those individuals, to be completely cautious, because we're not sure about the duration of protection from the 2-dose pre-exposure series, the ACIP recommends RIG plus 4 doses of rabies vaccine if they have an exposure beyond year 3. So this I know is different from WHO, so I wanted to emphasize this, just that the US ACIP felt that more data needed to be available in order to ensure that the 2-dose series provided protection beyond year 3. And so if someone did not get that titer or booster dose to confirm that they have protection beyond year 3, then they would be considered not previously vaccinated if they had an exposure beyond year 3. So there's other things in clinical guidance that we commonly get asked. One of them is co-administration of IM rabies PrEP and chloroquine, or drugs related to chloroquine. For immunocompetent persons, there's likely no concern with co-administration, but out of an abundance of caution, we do recommend checking the antibody titer for rabies no sooner than 1 week after PrEP, but ideally 2 to 4 weeks after, just to ensure that there was no impact. There's no concern with co-administration of Malarone or doxycycline, and there's limited data about mefloquine and rabies prep co-administration. So PrEP in special populations, it's safe and effective in all age groups, including children and the elderly. In terms of immunocompromised, we do have the same recommendations as for immunocompetent patients, but we do recommend additional steps. Ula mentioned this a bit. We worry about whether immunocompromised patients are going to mount appropriate antibody levels. And so for that reason, we do recommend a titer check after completion of the vaccine series, no sooner than 1 week after, but ideally 2 to 4 weeks after. And we don't recommend that titer check that routinely for people who are immunocompetent, but we do for immunocompromised. And again, if that titer is less than 0.5, then you give a booster dose and you check the titer again. But if it's greater than 0.5, then nothing additional is needed. And we have had situations where patients are severely immunocompromised and they remain, despite 2 booster doses, their titers remain low. And for those special situations, we provide one-on-one consultations. They can be complicated, and people can be very severely immunocompromised, and these situations can be very complicated. So this can obviously pose problems for people who are last-minute travelers and immunocompromised, but you can expedite titer results in the US if there is a call made directly to the laboratories that perform these testing. And I have some of that information here. Before sending the specimens, the laboratory can be contacted directly, typically via phone call. If the medical situation is explained and there's awareness from the receiving end that you will be shipping the specimen, then they can often expedite that, at least here within the US. The implications of the updated recommendations is that more people who are recommended to receive PrEP will receive it. What we had been seeing in the US was that because it's a 3-dose series and people often only see travel providers a week or so before they travel, they weren't getting rabies pre-exposure prophylaxis. And so this 2-dose series is obviously going to be beneficial to those individuals who are traveling soon afterwards, even if they have risk beyond 3 years, because we have that booster titer option later that can be done. It also might allow for more people to receive pre-exposure prophylaxis who are veterinarians and veterinarian technicians. We also found that some people didn't adhere to the recommendations for serial titer checks, but now many of these persons are in risk category 3 and require only a one-time titer or booster dose. So that might be more easy to adapt to. And to ensure travelers in risk category 3 receive the one-time titer or booster dose, the appointment for these might actually even be scheduled at the time of the 2-dose PrEP series. So there's nothing keeping someone from getting that 3rd dose as soon as 21 days, which is the previous 3-dose schedule. And some people have said that it's easier just to simply think of this as a 3-dose series and say people can go ahead and travel after that 2nd dose and receive that 3rd dose later. But that's another way of thinking about it, just a flexible series. The 2-dose PrEP plus booster can be given as soon as day 21, as I recommended, providing up to 3 years before the decision is made about whether long-term immunogenicity is needed, may be valued by stakeholders. But it is possible that because our minimum acceptable rabies antibody titer is now 0.5 IUs per ml, which is aligned with WHO, but it's higher than what we previously had in the US, that there are more people who will require that booster dose when we have that booster check, that titer check within 3 years of the 2-dose series. And we are actually already seeing that. And that's not really a surprise to us. It doesn't necessarily mean that people's protection is waning. We've tried to explain that antibody titers, circulating antibody titers, is not necessarily an indication of people's protection, but it is still creating alarm. And so it's worth knowing that if a titer check is chosen, that it is often lower than 0.5. and requiring a booster dose. So a few things to compare the ACIP schedule to the WHO schedule. Both involve the 2-dose schedule with doses administered on 0 and 7. WHO, there are different considerations. The exposures are typically dog bites Immunogenicity is confirmed at year 3. Long-term immunogenicity is assumed with the 2-dose series alone. As I mentioned, ACIP was hesitant to change the 3-dose series unless there was compelling evidence. They felt that immunogenicity was not studied enough beyond year 3. And so they took the conservative approach. So they took a conservative approach that evidence indicates a titer at 1 year is a marker for long-term immunogenicity, and that taken together, the one-time titer at 1 to 3 years or a booster at day 21 or at some point between day 21 to 3 years would provide that long-term immunogenicity. And that's the reason that these two differ. And it might be easier just to think of this as a flexible 3-dose series. Some people have thought that that's the easier way to look at this. Vaccine, this is just another way of saying the same thing. WHO felt that the vaccine-induced memory B-cell response was previously shown to persist for life, and the same is assumed after the updated 2-dose PrEP series, so there's no titer or booster dose needed for travelers. ACIP, as I mentioned, felt that that could not be confirmed, and that's why they recommend the one-time titer check or booster dose. The other things, PrEP schedule and guidance, are very similar between WHO and ACIP. As you can see from this slide, co-administration of chloroquine and rabies vaccine is likely okay. PrEP can be given to pregnant women, immunocompromised persons, and children. And regular serologic monitoring is recommended for people at with occupational risk factors, and a booster should be given if the titer is less than 0.5. So now I'll move on to the PEP schedule, but I just want to show first how WHO and ACIP differ before I go into this. So WHO recommends rabies immune globulin plus the 3-dose series. ACIP is continuing to recommend the 4-dose series. So similar to the PrEP recommendations, they're asking for more data to evaluate the effectiveness of the 3-dose series before it will be considered. There are some differences between WHO and ACIP just in terms of the population. So the exposures that WHO is facing are most often large bites and from large mammals like dogs. Rig administration is limited to infiltration around the wound. But in the US, the exposures are most often from small animals, typically bats. As much rig as possible is recommended to be given around the wound site, and the remainder administered intramuscularly at a site different from where the vaccine was given. For both WHO and ACIP, Ula already alluded to this, the rabies vaccine should not be administered intramuscularly in the gluteal area. And for both, now that ACIP is aligned with WHO, the minimum acceptable antibody titer is 0.5 IUs per ml. So the take-home messages here is that the ACIP recommendations that we thought very carefully about these. They're based on evidence. They're equally efficacious to previous recommendations. Now with that improved flexibility to encourage adherence, to encourage more people to be vaccinated, travelers' health providers in particular should be aware that immunocompromised persons should receive a titer check after the 2-dose PrEP series. Testing can be expedited. A titer or booster is recommended for risk category 3, which allows for the flexible options that I pointed out. And public health authorities are available for consultation. Now, moving on to more details about PEP. The PEP rabies, it's rabies vaccines. And again, I told you the number of vaccines differs depending on whether it's ACIP recommendations or WHO. And then also whether or not to give RIG also differs. The role of rabies immune globulin in preventing rabies is providing passive immunity before vaccine-induced humoral immunity occurs, given only to persons who have not received PrEP or previous PEP, and does not negate the need for PEP vaccines because at least some rabies virus is expected to travel to the CNS. The WHO position statement prioritizes RIG only for certain populations because there's limited RIG to high-risk people with category 3 exposures, multiple bites, deep wounds, bites to highly innervated body parts, persons with severe immunodeficiency, exposures from confirmed or probable rabies cases, and exposures from bats, limited rig infiltration to rig that can be infiltrated into and around the room, and there's wound and no IM administration. The maximum dose is 20 IUs per kilogram, and WHO recommends diluting rig if there are multiple wounds. The US guidance, though, is that if RIG should be administered, so if someone did not get pre-exposure prophylaxis, then it should be administered around the wound, and the remainder should be administered intramuscularly. And it is, again, the 4-dose series that the US continues to recommend for people who are naive. That is, people who did not receive either post-exposure prophylaxis previously or pre-exposure prophylaxis. So what we recommend in the US is that RIG be given to someone who did not previously receive the complete series of recommended PrEP or PEP. So here you can see someone who hadn't had their first ever exposure at age 40 and required PEP. They therefore got RIG and the 4-dose vaccine series after there was thorough wound washing that was done. And then for someone who did get pre-exposure prophylaxis and it's been greater than 3 years, then they would be considered naive still again, and they would need to get RIG in the 4-dose vaccine series because they did not ensure long-term protection through either a booster dose or a titer check. And then for those obviously who did get the booster or titer check, then it's just the 2-dose series and there's no RIG indicated. I just want to spend a couple of minutes here talking a bit about rabies infection despite PEP after zoonotic exposures. So we published recently this publication that's referenced on this slide that was a systematic review of everything that we know about rabies breakthrough infections. So rabies infections despite initiation of any approved post-exposure prophylaxis schedule. So this was not limited to the US, of course, this was worldwide. And obviously there have been sporadic breakthrough infections that have occurred, but these cases seem to be relatively rare and associated with severe bites. We have a lot of supplemental tables and things in this publication that's referenced here on this slide that goes into this in more detail, but it's good news that these seem to be rare. In the US, though, we did have a patient who was an elderly male who appropriately got rabies post-exposure prophylaxis after a bat bite. And 5 to 6 months later, so a good period of time after receiving appropriate cell culture rabies PEP, he developed rabies. So he apparently was immunocompromised, but that was not known at the time that post-exposure prophylaxis was given. And unfortunately, this patient ended up dying. We described this in detail in this publication in CID. And I think Ula was referring to this paper when she described her study that has evaluated rabies titers in the elderly. So what we're saying is considerations for immunocompromised persons, that a titer check needs to be done after completion of the PrEP series, as early, and also the PEP series as early as at the time of the 4th PEP vaccination, up to 3 weeks after that dose. Additional doses as indicated by the titers. Expedited titer checks should be made before submitting the specimen that you could call before you submit the serologic specimen for testing, so that they can expedite that. If they know that it's related to an exposure, then they will. It's not known how many severely immunocompromised people will mount appropriate antibodies after additional rabies vaccine doses, and so prevention still is something that needs to be emphasized. In the US, we're still saying that we're not referring to all the elderly here. We recommend a very thorough review of systems to see whether or not there's any chance that someone might be immunocompromised and go based on that. But it certainly, I mean, it makes sense what France is doing, what Ula described in terms of checking titers on all individuals over a certain age. So that is our ACIP recommendations for both pre and post-exposure prophylaxis. And I just want to thank all the people who've helped with this work, and they're all listed here on this slide. Thank you.
Thank you very much, Dr. Rao. That was very comprehensive. The slides will be available afterwards, and a slightly different view there. So let's move on to our last speaker. We're sticking very nicely to time. Dr. Wasim Matsi is from the Thai Travel Clinic Hospital for Tropical Diseases in Bangkok, Thailand, and also the Travel Medicine Research Unit, Department of Clinical Tropical Medicine, Faculty of Tropical Medicine, Mahidol University, Bangkok, Thailand. And we all know that Thailand's got a little bit of a reputation for rabies exposure, and that's partially true, and therefore he's probably one of the most experienced persons on the ground in terms of taking care of people that have been exposed, both travelers and national people. Thank you very much, Dr. Matsi. Over to you.
Thank you, Rabies. And it is my pleasure to be here as a representative of my team, the Thai Travel Clinic, who have encountered with the patients with rapid animal exposures. So I would like to share my screen here. All right, so today I would like to share our experience on the case and rabies in travelers, especially in the setting of the travel clinic at the endemic area. So I have no conflict of interest for these presentations. So the outline of these presentations, I will discuss about the current rabies situations and updates on the situationals and cases, especially in Thailand, and also with the challenging in the post-exposure management in travelers. So I would like to start with this slide because rabies is really deadly. So this is the case of full-blown rabies in Burmese child who was bit by a stray dog in his village 3 months ago, and he didn't get any post-exposure vaccine. And 3 months after that, he developed the fevers, alteration of consciousness, and also with the typical clinical signs of rabies, which is aerophobia and hydrophobia in rabies cases, which is the typicals. So my professor usually say that once you have seen one case of rabies, you will remember in all of your life because it's very tragic. It's very sad story. So that's why today I need to encourage you to just encourage travelers or people who exposed with animals, rabbit animal to get post-exposure, and at least you encourage your travelers to get the pre-exposure. So the thing, is deadly, but 100% preventable for rabies. So this is the data of the situational of rabies cases in Thailand. So we cessations of the nerve tissue vaccine since 1992. And after that, we used cell culture vaccine almost 100%. And one other thing is that because of we did a lot of study on the intradermal vaccinations because it's cheap, safe and effective as well. And you can see that the trends of the rabies cases in humans and the rabies positive animal are decreasing over time. And this is the show you that after 1992, after we used the cell culture of the vaccine, the cases of human rabies is decreasing. And we have the Thai Red Cross Society, which is the main organizations who developed and conduct the study on rabies in our populations. And although the rabies cases have decreased, but rabies still exist. So we still have the stray dogs who carries rabies around there, and of course there's a lot of others rabbit animal which is carry rabies in the area as well. So one of the common pitfall in rabies death in our experience is that most of them are unaware of rabies risk. So when they exposed with the rapid animal exposure, they didn't seek for post-exposure vaccinations. And this is one of the things that the common pitfall, and they may get infections. And the unrecognized category 3 wounds, as the earlier speakers has already mentioned that the category 3 wounds have a high risk to get infections. and also with the improper wound care. So they usually lack of the wound care before they travel, and the main factor is that they don't get immunoglobulins and also the post-exposure vaccinations. Delayed treatment is one of the things, and direct nerve inoculation, especially in children. When you see the children who exposed with, dog bite, they usually get bite around the face and head, and usually severe wound after that. So sometimes the inoculates direct to the nerve, and the lack of the patients compliant with the vaccine schedule. So this is, I think you may familiar with this graph, is that even rabies cases among travelers is very rare. However, we still see the rapid animal exposure and animal bite is more common. So we as the travel medicines in the endemic area, we did some study to see how common bite exposure among travelers. So we did it in 2010, 2012, and the latest one is a cohort study in 2019. And we found that around 1 to 3% of the travelers visit in our regions may expose with the rapid animal exposure. And one of the interesting data is that only 1/3 of them seeking for post-exposure prophylaxis at the destinations, which is one thing that we should very worry about that. So what's about the post-exposure in the travelers? So basically, we have to note the epidemiologies of rabies in each countries, whether it's what's the common exposure, animal exposure that they have encountered. And of course, severity of rabies exposures by the WHO categorizations, and some of the species of animal and clinical features of the animal responsible for rabies. For example, you may heard about the sea who carries rabies in South Africa, and in Thailand, which is, I will talk about it later on, about rats or rodents, which is this is one of the potentially rabies carry animal as well, even it's not the mammal. So this is the study. They try to prove that what's the common rabies carry rabies in our regions. We found that dogs, cats, and cows, of course, this is the common mammal which is have the carry rabies as well. And one other thing is that we have one case reported of rat rabies in our regions. And the case is that he 45 years old farmers, he said that he fiercely attacked by a large rat in his house with multiple bites. And also he captured it and killed it. And of course, the rats was sent to confirm at the rabies reference labs in our country, and they confirmed with rabies. And unfortunately, these patients, he received immunoglobulins and complete the post-exposure. The thing is that we know that the animal, even rats or rodents in our regions, may have incidental infections by attack by the common rabies potential carries virus like dog or cats or bats in our region. So they may have exposed with this kind of animal. So that's why in our regions, we prefer to give rabies post-exposure in rats or rodents bites or exposure in travelers, not just really travelers, but also in local as well, to be a safe side that, okay, even they don't have a strong evidence that rabies cause rat bites cause the human rabies. However, we found that the rodents and bats have potentially carry rabies virus as well. And also in our regions, of course, we follow the category wounds by the WHO. However, they have some exotic activities. For example, you may see that Asians culture cuisine, they have some raw ingestions of raw meat as the cultural cuisine as well. So the question is, if the animal which is died and they cook like this, what's the category that we would consider, because they might need some management as well. So in our guideline for the ingestions of the raw infected meat, we usually consider as the category 2. So why? Because on the categories, that means you will lead to the management. For category 3, you need to get immunoglobulins and post-exposure vaccine. However, once you eat raw infected meat, so how do you administer the immunoglobulins, right? You cannot, you cannot drink immunoglobulins because it's ingestion. So that's why we categorize it in category 2. So previously we categorized it in category 3. That means you need immunoglobulins, but we face some problems that how do we administer immunoglobulins? So we moved from 3 to category 2 in the ingestions of the raw infected meat. And also I would say some of the travelers, sometimes they try this kind of exotic cuisine as well, but be careful that especially in the unexpected death, cows or animal in the rural area may caused by rabies as well. So this is the cases that we have reviewed back in 5 years, including during COVID-19. We reviewed 300 travelers with rabies post-exposures, and we found that most of them are from the Western European, is a majority. And interestingly, that around 1/3 received the pre-travel consultations, but only 1/3 among the one who receive pre-travel consultation complete rabies pre-exposure. And the time to get bitten that we found is that mostly, majority is more than 4 weeks of the travel. However, we still see around 15% of the traveler who just traveling no more than a week got bitten in the regions, which is, I usually say that the time of traveling is not the factors. You can get bitten on the first day you arrived in the destination. And the rabid animal that they have encountered is dog and monkey and cats, and sometimes rabbits, rat, and squirrel as well. And the majority of the cases are from the category 3. Most of the country of exposure is in Thailand, majority of them. So when we analyze to what's the appropriate rabies post-exposure management identify among the travelers who sit at, we found that more than, almost half of them delay rabies vaccine. Get exposures and they delay the first dose of the vaccine. So you can imagine that the rabies vaccine and the rabies immunoglobulins may not available throughout the regions. In Thailand, we believe that rabies vaccine is available throughout the country, and also with the rabies immunoglobulin as well. At least in one province, you have one center that provide the rabies immunoglobulins. However, sometimes you may have the problems to access the immunoglobulins and vaccine. But outside Thailand, in other countries in Southeast Asia, the immunoglobulins and rabies vaccines may be difficult to find, especially in the tourist destinations. They may available just only in the capital city or in the big city, which means you may need to goes to that center that may interrupt your travel as well. And we found around 1/3 that delay rabies immunoglobulins. Around 20% they have incorrect schedules, and and around, 70%, we found that they got the inappropriate immunoglobulins. So some of the physicians, they still administer the RIGs not in the not every wound. So they just, sometimes they forget to infiltrate the immunoglobulins to all the possible wounds that the patient's exposures. So what we have learned from our cases is that we still have the travelers and also with the healthcare provider unaware of the rabies risk. So we have one case that the US travelers who travel around the world, and they travel through South America, and they got bitten in Guatemala. And at that time, the travelers, they seek for post-exposure, and the vaccine is not available in that area. The thing is that she just received the tetanus vaccine, and the doctor just advised her that, okay, you should get post-exposure where the vaccine is available. But the travelers, they travel all the times from South Africa around, at least 6 months until they visit us in Bangkok after 6 months. And she just need to get the pre-travel counseling to other vaccine, essential vaccine for Southeast Asia. However, we saw that they have the records of tetanus in Guatemala, which is quite striking us. So that's why we asked them that, okay, why did you get a tetanus in Guatemala? And she just, tell us that, okay, she got bitten by a dog, and they don't have rabies vaccines, and the wound is category 3 as well. So at least, we start to manage them as the first day of exposure with the post-exposure vaccine. So as I told you that as we know that knowledge and attitudes and practice is alarmingly inadequate, we have seen lots of travelers have improper wound care before visiting us, because in the wound care, it's the first aid that can cleanse the wound and can cleanse the virus that inoculate at the bite site as much as possible before you get into the vaccine or immunoglobulins. So this is the important thing that we usually counseling to the travelers who get the exposure for the vaccine. And delayed treatment, of course, this is one of the things that we have seen, and we have learned that a lot of travelers, they got bitten while they travel, and sometimes they seek for rabies vaccine or immunoglobulins, but the immunoglobulins and vaccine is not available in that destinations, and they forgot it to get it after they recognize it again when they return to the city or the home countries. And the other thing is that we have to know the rabies distribution around the world. As I told you, that we can see the travelers who got bitten from other countries, not just with Thailand as well, and they might get some countries and continue the post-exposure, or even unrecognized with the post-exposure after the exposed. And of course, the prevention is the key. As I told you, once you have seen the case of rabies or rabies cases, you will remember in all your life. So you have to aware of this. It's an educational and logistical problems, especially in our regions. So the rabies post-exposure challenges in the travelers that we have encountered is that first is the improper wound care. This is one of the things that we have seen, and it's just the important steps before going to the healthcare. You have to counseling them that once you get bitten, especially category 2 and category 3, they should cleanse the wound as much as possible. So the guideline, they usually say that you have to cleanse the wound with soap, with the rinse water, and at least 15 minutes before going to get the post-exposure management. And also with the limited access to the immunoglobulins and vaccine, which is one of the problems, as I told you, that some destination in our regions, they don't have immunoglobulins available, and also with the vaccine as well. And of course, the travelers, they continue traveling. So sometimes they got the schedule or they got post-exposure and they continue traveling. And sometimes they delay to get the, another dose on the schedule because, they're still on the travel, and also some destination, they don't have it's available or inadequate schedule. And one of the important thing is that in our regions, we have different post-exposure regimens, which I will show you in detail later on. So this is a rabies vaccine for human in Thailand. We have we don't have human diploid cell cultures, but we have purified chick embryos. We have purified viral cell. We have chromatographic purified viral cell. And of course, fortunately, is that the price and the cost of our vaccine is quite cheap compared to others. Others countries. So it's estimated around 12 to 15 US dollars. This is a price in government hospital. However, in the private setting, it might be 2 or 3 times more expensive than this. And of course, we use the rabies immunoglobulins in the patient, especially human rabies immunoglobulins and equine rabies immunoglobulins. So human rabies immunoglobulins may not available throughout the regions because it's quite expensive, but we usually use ERIC, which is equine from manufacturers from the horse serums, rabies immunoglobulins instead. So this is the ERIC or equine rabies immunoglobulins that we have used, which is, many countries, we have manufacturers by the Thai Red Cross in our countries, and some countries in Southeast Asia have imported these immunoglobulins to use in their country as well. As I told you, it may not available throughout the countries. And the price is not that it's cheap compared to the human rabies immunoglobulins. And of course, this is the government price, so you can expect it that the private price might be more expensive. So the post-exposure prophylaxis that we have used the Thai Red Cross regimen, which is ASCENT regimen. It is in the intramuscular on day 0, day 3, day 7, day 14, and day 28. So number of visit is 5 visits within 28 days. And we have used our own recommendation, which is approved by the WHO as well. We call the Thai Red Cross intradermal. As I told you, it's cheap, safe, and immunogenic from our study. This is 2 site ID on day 0, day 3, day 7, and day 28. Within 28 days as well. So they have another regimen in the WHO recommendations on the left side here. And one other thing, as I told you, is that the rabies post-exposure regimens in the region is quite different. So this is the summary of the current rabies post-exposure regimen in Southeast Asian country, and you can see that one countries, they might have the recommendations in different guidelines. For example, this is the main regimen that we have used, which is IM, Song regimen, Zagreb regimen, and 4 site IDs, which is recommended by the WHO, IPC Institute of Pasteur of Cambodia, which is intradermal, 3 doses on day 0, day 3, and day 7, which is alternative regimen of post-exposure recommended by the WHO and Thai Red Cross regimen. So you can imagine that if you naive for the immune for rabies and you got the post-exposure, it's a little bit complicated to get one post-exposure regimen and continue another regimen in different countries as well. So in Thailand, I mean, in our practice, we usually align with our recommendation, which is 5 intramuscular and 4 intradermal. But in our clinic, I mean, usually our practice, we usually recommended intramuscular for travelers to avoid confusions when they're traveling to other countries as well. And this just shows the geographical distributions of the risk assessment. And you can see that most of our regions, the risk is available. In some countries, it may not available within 24 hours. So that's why, as I told you, it's because it's different in the post-exposure regimen. So I usually recommend them to get the pre-exposures before the travel. And fortunately, because the price of the rabies vaccine in our clinic is quite cheap, so we are more successful in the pre-exposure counseling on rabies vaccine because they can afford, especially in backpackers, that they can get it. And I would say this should be the first priorities to recommend to the travelers who are going to the rabies endemic area at the moment. So for the post-exposure for prophylaxis, especially in the ones who previously immunized, so that means you complete pre-exposure or you got the post-exposure vaccinations. So no matter what's the post-exposure regimen differentiations, but if you complete pre-exposure or previous immunized, you just need a booster. Either ways, I mean, in our recommendations, the Thai Red Cross is that once you complete, I mean, previous immunize and you get exposed less than 6 months, you just need 1 booster. If more than 6 months, you just need 2 booster on day 0 and day 3. This is also with the WHO recommendation as well. So no matter what route, they usually, especially if you exposed within 3 months, they no need to booster. And if more than 3 months, they may require to booster within 2 visits on day 0 and day 3. So complete the pre-exposure will help the travelers a lot on the confusion of the regimens or post-exposure management. So I would say this is almost my last slide on don't leave the travelers with don't get bite during the pre-travel consultations because sometimes you cannot avoid. Like this, you can see the dog, a lot of dogs in front of the mini marts in Thailand, which is sometimes you may get attacked by the stray dogs. And of course, this is my last slide that, okay, rabies exists and it can be prevented in travelers. And of course, the challenging in PEP management in our regions is complicated scenarios. And also, you should recommend them to get pre-exposure immunization and discuss with the risk in traveler as well. So, yeah, so I think you may know about hers on the pygmy hippopotamus. Will you get rabies post-exposure once you get bitten here? In Thailand, you may not necessary for that. So remember that prevention is the key. Thank you so much.
Thank you very much, Dr. Matsi, for a nice practical review of rabies around your part of the world. Everybody's stuck very nicely to time, but we just about to run out of time. There were lots of questions, but we will be answering them. I just want to make 2 quick remarks about other common mistakes that you referred to. And one is that we see physicians give tetanus vaccine post-rabies exposure and think it's the same thing. People who don't work with it on a regular basis, or they give pooled immune globulin, which is also not going to work for rabies because the general population where that pooled immune globulin comes from do not have rabies antibodies. And then you also pointed out that, seeing that we haven't said much about Africa, but it's extremely difficult to come by rabies immune globulin in most parts of Africa. And so your plea for pre-exposure vaccination it doesn't go unheard. I'm not sure, Yen, whether we're allowed to select some questions. We've got a number of good questions, but I think it'll be discriminatory if we allow some and not others. Yen, your opinion?
I think you could flag some that could be answered live, but we will try and answer the rest through a written handout that will be sent to all registrants after the session. Would that be okay?
Yeah, that's fine. You're putting me on a little bit on the spot to quickly select maybe one or two specifically. I think one of the burning questions for lots of people around the world is where serology is not easily available. What do you do? And Ula, I see you shaking your head, so you've just volunteered. You've just put up a hand to say you reply to that one. I think I know the answer, but over to you. Your sound's off.
Yeah.
Yep.
Do you hear
Got
me?
you now. Yes, we do.
Well, I did mention we have access to serology very easily in France, and I saw a few questions on the delay because they were saying in the US it's quite slow. We have the result during the week, and it can be done in any lab. So we have easy access to serology. In the paper where we discussed the vaccination in elderly, we did suggest for people who don't have access to serology, a solution would also be to do a fifth dose. We're used to serology, so we have the easy answer, but I don't know if any of the others have anything to add to that.
Dr.
Or you,
Matsi, do
Albie.
you have an opinion on that?
Because serology testing is not practical use in our regions, and we normally not testing. So that's why the schedule of post-exposure rabies that we used is almost 100% zero zero conversions in the trial. And of course we have some serology lab, which is reference rabies center in Thailand, just only one site that can test for serologies. And it's very expensive. And only the cases that we suspected, we send for serology. But normally, in general, we don't send for serology.
And is it fair to say that if you're not sure, because you cannot do serology, we're in the same boat down in Africa, then you would play safe and rather over-vaccinate or over-rabies immune globulin than not do it at all, or than to delay that? I think that's the practical answer. I've got one more question that is going to come from my continent as well. Dr. Nino Ruiz sits in Dar es Salaam, and she asked, do you have advice on the use of horse-derived immune globulin in case of human-derived immune globulin if it's not available? So if you only have equine rabies immune globulin, you don't have human rabies immune globulin. I think the practical question, why it struck a note with me, is if somebody is in a place like Dar es Salaam and you've got equine available but not human, and it's a person from France, Ula, where normally you would have human rabies immune globulin in abundance, you're spoiled. Do you let the guy get on the plane and go back to France for his human rabies immune globulin, or do you give him equine rabies immune globulin? We're sort of in the same position. We've got human rabies, but not all human rabies immune globulin, but not always enough. What would you advise your French traveler? Do you let Nina give you horse serum, or are you going to go home?
I mean, I would be pragmatic. I think they should stay and do the prophylaxis, get the equine. I mean, it's not as immunogenic, and it does induce more severe allergic reactions, but if that's what you have, then you still can do that. We prefer human, but if we don't have human, we can use equine.
Great. Dr. Rao, do you maybe want to give us an American opinion? I see you've got a lawyer looking over your shoulder.
Sorry, I was responding to things in the chat. So we're right. Can you repeat what the question was? I apologize.
So if you've got an American somewhere in Africa, and we can give the American, he qualifies for rabies immune globulin, but we only have equine available. Would you advise him to get on a plane and go back home to Atlanta and get human rabies immune globulin, or does he get equine? Because that's the majority of the people in the world probably have got more access to equine than human. What would you
recommend get the equine there in country
rather than delay? Okay. Is there another burning question? There were so many questions, but we'll get round to them. Dr. Yen, Dr. Bui, are we allowed to continue, or do we have to cut off? I think Yen actually had to leave us, if I'm not mistaken. Okay, Lynn, do you, as past press,
take this? Let's take another 5 minutes, and then the rest we need to write responses and post in a handout. Thank you.
Okay, perfect. We'll continue with that. So I'm going to choose another one. Let's see who else I can put on the spot. There was a question. So something that I'm also a little bit puzzled about. So I'll answer one quickly because I know Dr. Mati referred to that. So there was a question about can rabies occur in animals other than cats and dogs, etc. And that, I think that's because you referred to the fact that we've now got proven rabies in some of our seals in the Cape. It's a very squeaky clean place, so it's terrible for the Cape Townians that they've now got rabies-infected seals. But seals are mammals, and so any mammal can potentially carry rabies. And I think the other question, there was a question also referring to the fact that you referred to squirrels and rats as carrying rabies, and you had a proven case, but it was a very big rat. So we always say that we haven't had recorded cases of rabies in Southern Africa in rodents, and we haven't seen it in monkeys either. And it's probably because if a rabid animal gets hold of a very small other mammal, like a rat, they kill it when they bite it. So it's just because you've got a super big rat that your rat probably survived long enough to bite the human. So it's never say never. There's always a possibility, and you've got to do a risk assessment. Professor Bloomberg here always teaches risk assessment is what were the circumstances, and if you're unsure, then you err on the side of caution. Do you want to remark to that perhaps while I look for the next one?
Well, I would just add, I think it was the name of, like, it's deadly but preventable. So it doesn't occur. It's a rare occurrence, but if it happens, it's very severe. So I mean, typically for rats, we do see people who get bitten. We're not very convinced that there's a risk, but we prefer to always vaccinate because we feel when you look at pros and cons, I mean, it's better to vaccinate a little bit excessively than to take the risk of a fatal disease that cannot be treated. So
yep. So, and then the other question, it sort of ties in a little bit with that, is how long after a potential exposure is too late? So Dr. Rao, I think you sort of gave us an answer. If somebody rocks up more than 12 months after they've had an exposure, you're not going to give them a course of rabies vaccine, or would you?
We do in the US. I think Ula said that they do not in France, but so
I mean, we had to put a cutoff, and I once saw a patient who came 12 years after, so he was exposed. So I mean, there's a moment you need to put a cutoff. As you said, we can never say never. Maybe there will be longer incubation periods after 12 months, but we took the stance to stop at 12 months because the WHO does say it's very rare after 12 months. So the animal has to have rabies. It has to transmit rabies, and in plus it has to be of long. I mean, we arrived to very small probabilities, but I don't think there's an official limit in the guidelines on that.
I heard in an ISDM conference once that somebody, I won't say from which country, Ula, said that they were confronted with a lady who saw a program on bats, and then suddenly heard, well, a bat can potentially transmit something that looks like rabies. The purists will say it's not rabies, but you're going to die from rabies. And she had a bat in a hare 18 months before. And she presented the clinic and said she wants rabies vaccine. And that guy said he'll give it. And I was like, I'm not sure, because we know the closer to the brain the exposure is, the shorter the incubation period. So somebody getting rabies more than 18 months after they were bitten, potentially bitten or scratched on the scalp, I would say. And then there's somebody in the audience, I won't point her out, but she's British, who posed a very interesting question for those of us that live in areas that do not have easy access to rabies vaccine and rabies immune globulin. What is the better thing to do? Do you, in an area in Central Africa where there is quite a high risk of rabies exposure, do you vaccinate all your employees? It's an NGO. Do you pre-exposure vaccinate all your employees from a pool of vaccines that is necessary for post-exposure? Because you're depriving some of the local population when they're really at risk by giving pre-exposure. And that's one of the ethical issues we've got to think about in some parts of the world. Good. What else is there that is standing out? I'm feeling guilty about everything we're leaving out. There was a question. I hear a lot from US travelers saying that the cost of pre-exposure prophylaxis is prohibitive. What is the current approximate cost of a dose of rabies vaccine in the USA? Dr. Rao, that's yours again.
Yeah, I don't have the answer to that. I think someone in the chat mentioned that they've charged $390 per vaccine in their clinic in the US, but I don't have an answer to that. I could just say that we recognize that, it's travel vaccines are expensive. They can be expensive. That was part of our reasoning for trying to actually reduce the number of vaccines that someone would need before travel, 2 doses. And then that 3rd dose, if they do anticipate long-term need for rabies vaccination, could be deferred for a couple of years. But I don't have a specific cost.
I see Dr. Matsi is smiling at $300 and something. What's the cost of a rabies vaccine in Thailand?
So as I mentioned, this is about estimated around 12 to 15 US dollar per dose. And as I told you, this is one of the factors that I have successfully recommend rabies pre-exposure immunization for the travelers. And it's possible to get it in the travel clinic at the destinations because they require just 7 days. And it's very benefit to the travelers. And one other thing of the Yep. Go ahead.
No, continue.
Yeah. So one other thing that I have encountered when we counseling on pre-exposure of rabies is that the travelers, they misunderstand, they misunderstand that they understand that once they complete pre-exposure and they exposed with rabid animal, they no need to do anything, which is incorrect. So one thing that when we counseling them on pre-exposure of rabies vaccine, we have to counseling them that once they exposed, you don't need to booster unless you get exposed, and you don't need to get immunoglobulins. This is one thing that we need to highlight during the pre-travel counseling as well.
Absolutely. And I just want to put a little bit of perspective, a different perspective on that. So in South African terms, rabies pre-exposure vaccination is also expensive in our terms, and I'm just off the top of my head, it's about $35. So it's 1/10 of the price in the United States. However, I've been involved with 3 cases where Americans in 2 cases, and one was from Israel, had serious rabies exposure. 2 cases actually occurred in Malawi, and where they then, because we cannot find rabies immune globulin and they didn't have pre-exposure and they have to have it, they have to fly to Johannesburg to come and get a post-exposure vaccination and rabies immune globulin. and that the insurance companies do not cover that because they don't see it as a life-threatening situation, which is terrible. I hope there's a lawyer out there listening. But when you compare the cost of $700 pre-exposure versus you're now talking thousands of dollars for a disrupted holiday or work, and change of travel plans, air tickets, accommodation, etc. That's something to consider when you decide about pre-exposure vaccination or not, however expensive it is. I see our past president glaring at me from the bottom of the screen. I think we've done our 5 minutes. Is that correct, Lynn? Or would you like to add something?
Those are amazing, wonderful comments and real life experiences from around the world. So on behalf of ICM, I want to thank everybody for your presentations, your insights, and wonderful moderating. And we have many continents represented here and raising issues that we all experience. So I think it's a great segue into have more conversations in at CISTM, which is going to be in New Orleans in May of 2025. So I hope many attendees will be coming. And thank you again, everyone. If there are remaining questions, I wonder if those can be assembled and we can put that into a handout. So thanks again.
Absolutely.
And I responded in the chat. Yen said it was okay to do that. So I think I responded to a lot of them in the chat. I don't know if those also will be compiled, but just wanted to let you know that I did that based on what Yen said.
Perfect. Thank you very much. Good. Then with that, we conclude today's online program. A special thank you to our presenters, all three of them from different parts of the globe. Lovely to have that. And to all our participants. I think we had at some stage close to 400 participants. Thank you very much for joining us. And again, a special thanks to our sponsors, Bavarian Nordic and Sanofi, that helped provide this program. It's money that makes the world go round, unfortunately. And at the conclusion of the webinar, there's a survey link available on the contents tab of this program, located at learning.istm.org. You will find the webinar page on your dashboard once you are logged in. Please take a moment to complete this brief survey, as your comments and suggestions are important to us as we plan future events. And for anyone claiming continuing professional development credits, the certificate can be downloaded on the contents tab of this program, located at learning.istm.org. After the webinar and survey are completed, you will find the webinar page on your dashboard once you are logged in. Everyone joining us today receives access to the on-demand active recording of this presentation, and you will be notified by email when the recording is available to view. If you have any questions about today's webinar or have any issues accessing the survey, CPD certificate, or on-demand recording, please email learning@istm.org. And now I know exactly what those radio presenters feel like when they make it sound like they really use the soap powder that they sell. And that concludes today's program, and you may now be disconnected. Thank you very much. Thank you very much to everybody.
Thank you.